Thank you. Welcome for folks who've joined. I'm sure there may be people who come in along the way, but we can start. I'm going to just start with some general comments and then hand it over to Stacey, who's going to facilitate a conversation. I think, as people probably know, in this field, that we have a journal. As well as this meeting, we have this journal called Health Literacy Research and Practice. Stacey's on the editorial board. I'm the editor. Over the last year or so, we began to have author submission fees. But anyone who's come to this conference can have a waiver of their APC. And the code on the website for an APC waiver is just HARC 2023, as it says on the slide. If you have questions about that, please let me know. In general, the APCs actually only apply to original empirical studies. There are other submission formats anyway that never had APCs. And then also people from countries underdeveloped for research funding also have waivers as well. So with that, I'm going to turn it over to Stacey, who can explain what we're hoping to do.
Great. Thanks so much, Michael. So I'm Stacey Bailey. I'm an associate professor in Division of General Internal Medicine at Northwestern University in Chicago. And just going to be leading the session today, which I'm hoping can be somewhat informal and really just an opportunity for us to meet one another and to chat about measurement issues with health literacy, and potentially look for collaborations and explore different topics for discussion. So there are a fair number of people on the call, but I would love to just go around somewhat briefly. If you can just say your name, maybe your institution and your research interests, and I can call on folks just based on the order in which I see them. Michael, did you want to say something?
Just a few things, which is because this is an interest group session, if you're able to turn your camera on, that'd be great. At least awesome. When you're talking, that'd be great. In particular, people may have many different types of research interests in health literacy, but in particular for this session, as it pertains to measurement, if you might, however you define that.
That'd be great.
Yep.
No, it's perfect. This is my first time doing an interest group on Zoom, to our earlier conversation, Michael, so it might be a little bit interesting, and we'll have to kind of figure things out as we go. So I think the first person that I see on my screen is Greg O'Neill. Can I just pass it to you? Lucky you.
Hi there, Greg O'Neill. I'm the Director of Patient and Family Health Education at Christiana Care in Delaware.
Okay, great. Any health literacy kind of or measurement related interests in particular, or are you just?
I'm curious to hear if there's any discussion about screening, because I know we've had the universal precautions for a long time, but as folks lean into measuring other social determinants of health on screeners, I'm wondering if it would be helpful for us to play in that space.
It's an interesting topic, yeah, for sure. Jane Sims.
There we go. Jane Sims, and I'm the manager of patient education with Intermountain Health. And I kind of have the same thoughts as Greg, really curious about aligning this with our social determinants of health screening and how we can build on what we learn there.
Okay, great. It looks like Jean Newell. I'm sorry, I don't know everyone's names.
Yeah, Gloria Newell. Hi. I work at Rady Children's Hospital, San Diego, in the oncology department. I am a parent liaison, and my interest in this is we're developing a program to educate parents about clinical trials.
Okay, great. Janet Acosta Hochschild.
Hi, good afternoon, everyone. I'm Janetta Costa-Hopshe. I am a research health educator at Rutgers Cancer Institute in New Jersey. So what I do is I promote and I provide health education about cancer clinical trials, but the basic concept of clinical trials in the within the Latino Hispanic community. Thanks.
Great.
So maybe Gino, I think it is, maybe we can chat in the future.
Perfect.
That's very interesting. And I work with Latinos a lot.
Yeah.
You know, that's my primary language is Spanish.
Excellent. So my interest will be in the future, just write down an article regarding the different misconceptions and how we can improve health literacy regarding cancer treatment, clinical trials among the Latino community. So we'll see.
Yeah. So
Thank you.
yeah.
Great.
Well, I'll put my email in the chat for you. Okay.
Awesome. Okay, Amy Faust, and I'm sorry, I'm sure I'm butchering everybody's names. So I will try my hardest, Amy.
I'm Amy Faust. I'm the Health Promotion Manager at Bergen's Promise, a nonprofit in New Jersey. Interested in sort of research and practice in terms of the role of health education specialists in brokering some conversations about health literacy and health communication, especially in integrated care, dealing with youth with mental health and physical health challenges.
Great, thank you. All right, Sean's already prepared me. Sean Steidinger. Am I close?
Dead on.
All right.
Yeah, I'm Sean Steininger, and I'm a clinical services librarian at the University of Utah's Eccles Health Sciences Library. And I'm interested in researching adolescent and young adult health literacy and how librarians can partner with teachers and clinicians to increase their health literacy.
Okay, great. Michelle Anderson.
Hi, I'm Michelle Anderson. I am a parent in the Family Centered Care Department at Stanford Lucile Packard Children's Hospital, Stanford. And I'm interested in measuring health literate patient education, the impact of that, both in the verbal teaching, but also in handouts.
Gotcha. Okay, Jennifer G.
Hi there, I'm Jennifer Gallivan. I'm the program director in community engagement and communications at Alberta Health Services in Alberta, Canada. And we're just starting out on our formal program around health literacy. So I'm here to just listen and learn and hear what everybody else is doing and or has done and what's out there in terms of measurement. Thanks.
Great. Inga Zedvinskis.
Hi all, my name is Inga Zedvinskis. I serve as the Assistant Director of the Community Core at the Helene Fold Health Trust National Institute for Evidence-Based Practice in Nursing and Healthcare. Deep breath, at the Ohio State University College of Nursing. So greetings from Columbus, Ohio. I'm a nurse scientist. I am interested in health literacy measurement from the perspective of hopefully designing some interventions and then basically looking at the impact of those interventions. So like pre and post, so things that are easy to understand with minimal respondent burden that are valid and reliable that have been psychometrically tested. So in the health literacy toolkit was awesome. The resource that we have there, but I'm always curious about what's new and what's coming up in the field. So thank you.
Great. Grace Germano?
Hi, sorry, I just popped on a bit late. I missed the assignment.
Oh no, just say your name, where you're from, and if you have any interests specifically related to measurement for health literacy.
Oh, sure. My name's Grace. I'm from Ottawa, Canada. And yeah, I'm just interested in learning about health literacy measurement overall. And we've been working on some organizational health literacy measures within our organization. So this ties nicely into that.
Okay, great. Dana Ladd.
Hi, everyone. I'm Dana Ladd. I'm the Health and Wellness Librarian at the BC Medical Center Health and Wellness Library at BC Libraries. And I work a lot with patient education and teaching health literacy classes. So I'm just mainly interested in learning a bit more about measuring health literacy.
Great. Cheryl Scott, I think you popped up.
Hello, everyone. My name is Cheryl Scott. I am the director of the nursing program at Wisconsin Lutheran College in Milwaukee. Have been interested in health literacy for a very long time, and have now really tried to do some things to integrate the topic into the nursing curriculum and helping our nursing students understand the importance of health literacy.
Great. Lisa Ramos? May not have them. Okay, how about Alex Nicolucci?
Yes, hi. Hi. Perfect. Thanks so much. My name is Alex Nicolici. I am the health educator for the infectious diseases branch at the California Department of Public Health. And I'm really passionate about health literacy, and my work involves, creating resources for a general California population. So I'm just sort of interested in learning more about measurement tools and things like that. So thanks so much.
Great. And then I just have someone named Elizabeth, so I'm not sure. Yes. I think you've unmuted, but I can't hear anything. No? Okay. Julia Sam?
Yes, hi, I'm Julia Sam, and I'm from the Professorship of Adult Education in Germany on the University of Würzburg, and I'm interested in kind of the integration of health literacy in adult education organizations and the relationship between adult educators and the participants in adult education regarding health literacy, of course.
Great. Caitlin Walker?
Hi, can you hear me?
Yes.
Oh, hi. My name is Caitlin Walker. I work at Community Healthcare Network. We're a network of FQHCs located in New York City. So I am a manager of training and education. I also run our health literacy department. We say department, we are a team of two. And so we create all of our patient-facing educations for our patients. We create the materials ourselves, and then we run health literacy trainings both internally and externally across organizations in New York City. And I think measurement is the thing that always feels so evasive. I think that all health literacy practices feel really logical, and when you talk to people and you run trainings, everyone's like, yes, of course. And then you're like, right, so how do we prove that this does make sense? And so I'm really interested to hear what people say.
Great. Wonderful. Okay, I'll go a couple more. I know people are kind of hopping in and off, so if I miss you, then I think Michael Pascharola has asked for everyone just to kind of go ahead and say their name and where they are. But I will go ahead and say Julie Cox. I think I've got 3, maybe more.
Yes, hi, I'm Julie Cox. I work for Elsevier Patient Engagement. We publish small documents made available through EHR systems and at the point of care across the health continuum. I manage a small team of editors who do apply plain language to the clinical content, and the content is created by clinicians and reviewed by clinicians. And I'm just here to listen and learn a little bit.
Okay, great. Yeah, we have people hopping in and off, so I think I may have lost my theme, but if we can go ahead and have the others who maybe haven't presented their names go ahead and put in their greetings, and if you guys have any specific questions you wanted to talk about, please go ahead and put it in the comments. And yeah, so I do think it would be great just to start off. I know some of you are probably familiar with this already, but Michael Pascharola, if I can pick on you to maybe pull up the health literacy toolshed, I think that would be great.
Sure.
So for those of you who are not familiar, Michael and his team have put together this really excellent toolshed, which is basically an online tool where you can search a database that you can search to figure out what health literacy tool might be best for you. And I will let Michael talk about it. But that's the basic gist. And I use this thing a lot, I have to say. It's very helpful.
So I can tell you, so thank you, Stacy. So there's already way too many topics than we'll be like plausibly get to in this
Yes.
time. There's actually been some fantastic and very important questions that have been raised. And so unfortunately, like I'm sure we won't play, but just if people aren't familiar, I have this Toolshed website. This is mostly oriented towards tools that measure at an individual level, but we are looking to expand it to have tools that measure at an organizational level as well. And at this point, there's already 279 tools in the shed. You can see this screen, Stacy?
Yeah.
Yeah, and then you can filter based on various phenomena, like either the domain of health literacy that's being measured, or a specific health context or public health context of measurement, or the length of the tool, or other types of things. One of the really nice, another one is like the modes of administration. We're very happy to have just added text messaging because, as Stacy knows, there's a new tool for measuring health literacy via text messages as a new mode for us. And then also languages. So you can see here all these different languages. So for example, I think there was some discussion of Spanish earlier, just to show people what happens. You click on that, and then you get the subset of the tools in that language, and then you can go to them. You can also then, click on a tool, click on a thing, get information about it, or even when we're allowed to, permitting, but if we have the author's permission and appropriate copyright permission, you can go to the measure itself. And in this instance, the measure is actually in this article. So it's quite nice. You can also click here and you get more details if you want to review the psychometric properties of the tool, and things like that. So I don't want to take up too much time just reviewing the tool shed. If people haven't gone there and played around, I recommend doing that. We have been trying to have a mechanism for people to be able to see about a lot of the tools that have been developed. You can see from different parts of the world, people taking different approaches, self-report measures, test-based measures, and a lot of other features as well. So let me just pause there because there's a lot of other topics we might get to.
Yeah, and that's great. So for some of you who raise the question of, well, what tool do I use? That's a great place to kind of start the ball rolling and look to see what might be out there that might fit what you need and what your context is. I actually think, Greg, you started us off, and I thought you had a great question. I'd love to discuss that. So for those of you who joined a little bit later, Greg talked about screening for health literacy, and are we still thinking that we're not doing that for context? There's been kind of a push for a long time to consider universal precautions. So just always use health literacy friendly language when you're interacting with patients. Just kind of assume every patient has low health literacy, and you don't necessarily need to screen or measure patients' health literacy. Michael, I might pick on you a little bit because you wrote a great paper very early on about to screen or not to screen. That is the question. And, things have changed and evolved over time, and we are now asking a lot more questions about social determinants of health. And we're asking a lot more questions that, one of the reasons I think we didn't necessarily propose to screen previously was because it could be shame inducing, but we are asking questions now that are, very, very personal and very have the potential to cause some stigma if not done correctly. So I would love to hear from the group what everyone thinks about screening for health literacy versus not, and if you are, how would you go about doing it? So Michael, I might pass it to you first, just to say, has your opinion changed since that article?
No, so Greg, you point out correctly, with SDOH screening that we're doing, it's appropriate to kind of reconsider, because actually I've also been, trying to have health systems regard health literacy as a social determinant as well in and of itself. So, so there's two big pushes behind SUH screening, at least in the United States. One is that that states augment their rates for reimbursement based on this. So there was a very strong incentive for health systems to collect information, and it varies by state what variables need to be collected to get the augmented payment. In most places, the biggest chunk of that augmented payment is from housing insecurity, but it varies exactly what variables need to be collected. And really, I think there's a whole conversation to be had, like why we've done this and how we do this in order to make sure health systems that pay for a disproportionate share of disadvantaged patients, that they would have augmented payments to be able to do so. And it's acknowledgement that that actually takes a lot more effort. And, in no state is health literacy part of that calculation. So there's no augmented payment based on health literacy. Okay, so that's just, a functional matter. But there's another massive reason that we collected that data, is that we should then trigger services for patients on the basis of the information we collect. And if you collect information and find out that the person, say, has food insecurity, well, then that's something that we're trying to improve: access to services, access to benefits, and basically to identify people who need emergency food support and everything like that. And that's fantastic that's happening. Often, yes, but so then the question is, what are the services that you would provide if you identified someone had low health literacy? What are the special services? So in some places what they say is, well, we don't really have enough resources to provide educational support for all of our patients. We'll preferentially give them to people who, say, score poorly on this or that. And then it gets back to the topic of the screening paradigm and the logic behind screening paradigms. And so, Stacy, unfortunately, to this day, there still hasn't been a successful trial of screening and screening for intervention. So if you look at the U.S. Task Force, Preventive Guidance Services Task Force requirements for what you need for screening, it's not that screening could be stigmatizing. We screen for stigmatizing things all the time. But when we have an intervention that works, we know that it's acceptable to do so because we help people when we do that. To get to a point where we have data for a screening program, we need evidence that it works. At least that's my view. And so I have friends now on the U.S. Preventive Task Force Services guidelines. They would love to see data so that they could make such a recommendation. It means that as a research community, we should probably figure out to do such a study. And actually, they don't support things just on one study. They need at least 2 studies. They need multiple studies in different contexts before they say, yes, go and do this screening program. So I'm going to stop talking about it because I know that there are some health systems that do screening. I would say this is different than doing a project to see how common is this issue in my institution, and to use that as a marketing program within your institution to understand yourself and to help communicate amongst the providers and everybody across the enterprise. But for prospective routine screening, so I know this was done on the inpatient service at Vandy for quite a while. They took a different view. They've just routinely screened everybody on the inpatient service. I don't know if anyone's on who's got direct knowledge of that, other than the papers that they've written out of it. It has provided opportunity to write a handful of papers.
Okay.
I'll stop blabbing. You were there for a bit, right, Stacy, but in a different school.
With what do you mean? I'm sorry.
You have some familiarity with their program, with the
Vandy. Yes. I was to say I was not at Vandy, but yes, no, I do know what you were referring. Yes, and I do a lot of work with some federally qualified health centers that are in and around Chicago, And, you know, I have noticed that they do have health literacy in their SDOH screener. What I have noticed, though,
And
unfortunately,
how are they testing it? How are they?
that's what I'm about to say. I have noticed, unfortunately, that I think that it is based on provider perception of whether or not the person has low health literacy, which we know does not work. When it is even filled out, which is rarely. So, so I have not seen it well done. I don't know if others have had experience or have seen it well done. I would love to hear it if so. Other than Vandy doing the self-report, you know, subjective, I haven't really heard of it being done in a very targeted and systematic way. But Greg, can I pick on you and just say kind of what is your impetus behind that question?
I can tell you what's happening here, and we can all judge it for right or wrong. But we made enough noise from our team over the past few years. I think that it was at least on people's radar when they were starting the SDOH response. So that team included health literacy in a 9-question screener. I think it's 9 questions. Of course, they didn't ask us for which screening question to use. So they went so far, but not all the way. But they're using one that I think is like, okay. But what it has shown is that people will self-identify if we give them an opportunity. So in the year to date, January to now, with this live, I think in 1 or 2 practices, ambulatory practices as a pilot, where we've had, say, 2,000 people identify for a housing insecurity. We've had 250 identify as having to have someone help them with their medical information. So it's interesting to me, like, oh, my 250 people basically are raising a signal, like I could use some help. So then now I'm trying to work with that team. What are we going to do about that? To your point, Michael, what are the interventions that are downstream and that are scalable? So the main thing is, well, not the main thing. I guess the highest scalable intervention is that it's just a signal and a red flag to the care team that this person is asking for additional support. So circle back, do teach back again differently, just double, triple check on that patient maybe. We do have literacy organizations in the state that we can refer people through an electronic referral program. So we use Unite Us, but the Delaware version, Unite Delaware. So we can refer, if it's an extreme, identified literacy, straight up literacy need, we can refer them to a literacy community-based organization to help them as a support. But really, I was just kind of curious if anyone else is doing anything like this, just to try and experiment, because as you said, for internal business case making, Michael, most decisions are going to be made based on a signal. And if the signal is we should just be doing best practice, they're like, okay, without some sort of targeted thing to hang their hat on, or their budget on, or their impetus on, it can be a little bit tough.
Yeah, it's very tricky. I mean, education is part of SDOH screening in many places, but it usually doesn't lead to anything. Even if there's an offer for a referral, doesn't usually lead to anything. So it would be great to know how to tie the data coming into a program of support or whatever the intervention is going to be, and then that we would know that that's actually providing benefit to people, and then we could advocate for it. And I don't think we're there. So there've been I think there's basically 2 trials where people basically did a screening, then put a marker on the chart or message to the provider, and then look to see if this led to benefit to patients. But they were negative studies. So so far we haven't figured out how to do that.
Does anyone else have any examples where their institution has figured this out?
I was just going to add that we're a small nonprofit, but we do on a small scale. we do health education, intensive services for youth with mental health and physical health challenges, comorbidities. And so we incorporated the newest vital signs screening as one of our baseline measures, just to give our educators an idea of which families might need a little bit more intensive education, a little bit more one-on-one time, understanding discharge, paperwork, things like that. So we used it to inform our educators, our certified health education specialists in practice. And we'd be interested in seeing, you know, whether we can use something as an outcome measure for our intervention to see if that is helping families. We've had trouble deciding if we want to get rid of the screening or if we want to maintain it. We're currently switching some of our database programs and having that debate. So that's one of the reasons I wanted to hop on here. But it was helpful for us in terms of stakeholders and our board members and grant funders to be able to say this percentage of the kids that we're working with have low health literacy levels, or this percentage of the parents that we are working with are identified as having low health literacy levels. So we did find it helpful at some levels as a nonprofit, you know, searching for those grants and that funding.
Sure. Yeah, and to Michael's point, that you know, it's a different question, but I could certainly see how that would be useful for some to argue on your behalf of your organization, for sure, and to better understand the kind of demographics of your patient population.
So just to follow up about, you know, I think you said like outcome measures, and this is also something that's came up before as well, and you know, the health literacy tools that are test-based tools, at least, you know, were not actually developed to measure change,
right?
In particular, so like as an outcome itself, it's not really set up for that. The outcome of interest may be, for example, improvement in diabetes or improvement in asthma, whatever. They're in terms of whatever the disease scenario is, but that's different than thinking of health literacy as a mutable, changeable phenomenon that we then have a tool to measure that change and quantify that change.
Right, and we're thinking of it in terms of, you know, seeing for our overall program outcomes, are the families that are coming in at a low health literacy level on our screening doing better than the families that are coming in at a higher level? Are we being effective for both of those groups?
Yes, I think that's you know, there you're saying like, is our package of services mediated by this phenomenon, and can we make sure that our services are you know, basically overcoming the health literacy barriers that those families would be having, and so that we're not actually just promoting the, you know, disparities in some sense, right? So that sounds very doable and reasonable, even though, like, you know, NVS per se, I'm not sure. At least it's interesting to me because it's a test-based measure, and so it's not just like a relative phenomenon based on, you know, yeah, that's another thing I think people don't quite get. A lot of the self-report measures, especially the approach that's been developed like in Australia and in Europe, are for population studies. And that, I mean, they're developed for population studies. They're good for that because you can say, oh, how is our society doing over time? But that's different than, you know, maybe some of the scenarios like Amy, your example, where like actually you're a nonprofit, you're trying to provide services. It's actually a defined population, like, you know, not all of society, and how the health system is responding to it, and how the health system, yeah.
That's great. Does anyone else have any examples of what their organizations are doing, or any specific kind of questions about measurement?
I'm from Northwell Health. We do have universal social determinant of health screening when patients are admitted. Two issues with that is one, they use health literacy questionnaire from Health Lead, which is not validated tool. I did look at the health literacy shed tool and it was not there, but it's actually like very popularly used as like a SDOH screening tool. So that's one thing. And second thing is, when it was implemented, I was not involved. The way, so the nurses, when they do the admission note, they would complete, you know, patient's demographic, you know, all this information, and then they embedded these SDOH questionnaire as part of the admission note. Instead of putting the responses as yes, no, unknown, they just put the responses as yes or no. So no does not necessarily mean they were screened. So some of the patients who, like let's say intubated or altered mental status, I feel like they were all labeled as no. So when I was submitting my grant, I was looking at the data, and meta-analysis has shown that the prevalence of low health literacy among patients admitted with heart failure was 40%, but our data was like 1%. So, you know, we do have that data, but it was not like really
useful,
valuable data for me to use it in the future. So, you know, sometimes the intention is there, but then, you know, people who are implementing it, I feel like sometimes never thought about whether the data can be used in the future.
Hi, Yunji. It's nice to see you. Yeah, there's so many ways that these things can go wrong. You know, like the idea that the person who's like unconscious ends up looking like they have high health literacy or something because they, you know, it's just there's lots of ways these things can get messed up, and then we come afterwards and try to use the information for like research purposes, and we don't always have all the context in mind. And but what's this tool that you referred to? Maybe you sent, I don't know if you could post it in the chat. I'm not sure if I know it.
It's a health lead. I can definitely find it and then post it.
Yeah, I hadn't heard of that either. That's interesting.
It's the same one that our team, not my team, but our SDOH team chose.
Really?
It must have gotten like popular play on some SDOH playlist.
Huh. Health V?
Health lead, LEAD.
I can put it in the chat.
Yeah, no, I'm not familiar with that. Makes me feel better that Michael isn't too. So that's good. Interesting.
So this is Kathy Mead. So I've just been listening to this, and I've been in the field a while, and I know, Michael, we've talked. The whole topic of measurement is quite daunting. And when you look at the number of tools, what are we really measuring at the end of the day? I mean, I think we can measure if people might change in their problem solving. Can we move them to action? But it really is so contextually driven, whether it's diabetes education, oncology, or something like that. So, you know, we've used tools like the single item literacy screener more in a research setting, not per se in the hospital setting. And I guess I just bring up some skepticism about, you know, fully measuring literacy, because are we really changing literacy level, or we're changing individuals' ability to take in new content and be able to move them to something? So I just kind of want some thoughts from folks, what they're thinking if they've used actual tools, whether it's in a research setting, you know, what really is the outcome that we're looking for. I often approach it that it's a gauge. It provides us more information that patients or community members may need some extra guidance, some extra navigation, extra problem solving, and perhaps assistance with how they can best communicate with providers. Those outcomes might be a bit more tangible. But it brings back to what Michael said, that if we assess this in the hospital setting, what is it triggering, and who's going to address the triggers?
So for our health system, the way it worked was, depending on which one is triggered, it would automatically trigger a case manager or social worker to like be notified, and then depending on, you know, who's on the other end, they need to approach the patient and assess it, and then if it really needs to be addressed, then address it. So in terms of like addressing it, there was a follow through. It's just that the percentage of people who were having social need was much lower than it's supposed to be.
Yeah. So I also see a question in the comments from Elizabeth about any tools or questionnaires that can be used virtually over the phone for a service consult. And Elizabeth, you might want to check out the Health Literacy Tool Shed for questions like that, because they do have different tools that you can look at. And there are also some tools, like, for example, the NVS that, have been done also over Zoom, even though they were not originally maybe validated or created in that way. So that might be a good thing for you all to think about if you have a session with navigators. Great. And then, oh, great, thank you. So, and then I also see another question here on the side about pediatric patients and looking at health literacy of caregivers and the child. It's a very interesting comment. There's not been maybe as much health literacy research to date looking at caregivers, either of children or caregivers of spouses, and their role that they play. There's certainly been some, but less than looking at the health literacy of the individual. We actually just had a conversation last week with someone looking at health literacy between spouses, and not necessarily in a caregiver relationship, but just how much does one person's health literacy maybe affect another. And so, it's a very, very interesting question. I think I will admit that I have not done very much in the caregiver, at least child caregiver health literacy space. But that is another one. Michael, correct me if I'm wrong, but you do have that also in the tool shed in terms of caregiver. Is that right?
There's several caregiver tools. Probably the best validated ones called the FLAT. Jumping for pediatrics, there's the word caregiver there. I don't think there's anyone for like caregivers of patients with dementia, like on that side of the spectrum, but right. But the PHLAT, that's Russell's group developed that, and also had with Lee, and it was a pretty big collaboration. That was for the Green Light program that they had done. So there's but there's a few others in there as well. I don't know, Yunji or Greg, if you're able to actually post the items. I couldn't get them out of the site. Thanks.
Yep, great.
There's many questions. There's many embedded issues. There's a question here about how when we confuse people with our surveys and everything. It absolutely happens all the time. And there's many ways that we can even, to Yunji's point, get confused when we end up with the data, because I've been seeing, for example, Yunji, that missingness is not at random. So when we have confusing surveys and or patient reported outcome measures, usually people are limiting their analyses to the responses that they have, and often don't incorporate the concept that the missing data is not at random. And so, if missing data is preferentially for people with low health literacy, then you may really miss the boat on what the data means. And so I've seen this now in a few cases. This is maybe not as dramatic as like saying everybody who's intubated has high health literacy, but it's kind of another example of where you end up with missingness and then could easily misjudge the meaning of the data. Thank you, Greg.
Yes, I'm looking at this now too. It's interesting, the social needs screening tool. Are there others? Just out of curiosity, since we already have 2 people on the call that are using this, are there others that are using it as well? Anybody else? No. Okay. Or whose institution, I should say, is using it?
Oh, yes, but okay. So, but what's the health literacy component? This is a SDOH tool.
I'm still trying to open it. Sorry, I can't see it. Do you ever need help understanding what your doctor tells you, or help reading health information? Is that
I see.
That basically it?
There's one in there. Do you ever need help reading hospital materials?
I see.
So there's
So
the
that's
self,
like a,
I mean,
yeah, it's like a
the
version of
self-report
this.
questions.
It's a version of the sills, basically.
Yeah.
It's yeah. So something's a little odd if it ends up with Yunji ending up with 1% people who test positive.
Yeah. Yeah. No, for sure. So I'm trying to think about some other different topics that folks had raised when they were kind of going around the room. So it seemed like there was a lot of interest in cancer, if I heard that correctly, and there's also a fair bit of interest in non-English speaking populations. So, again, I can refer some folks to some different tools that are available in non-English languages in the tool shed, but it does open up a whole nother kind of can of worms when you're thinking about health literacy, and it's how it overlaps with limited English proficiency or speaking a language other than English in a healthcare setting. So I don't know if any of the folks that are doing a lot of work in that space wanted to have any comments or talk about. Oh, sorry. Go ahead.
No,
Michael.
just before that, Lise, you wanted to invite people to your poster, I think. I don't know if you can unmute yourself.
Yes, I can unmute myself. So yes, I'm Lise. I just posted something in the chat. I just wanted to draw your attention that I present a poster here, and that the poster is dealing with a measurement tool that was designed to measure the health literacy of adolescents. This is actually a tool meant for education. And the tool uses educational tasks as ways of measuring health literacy. So it's not a self-report instrument, but it's really an instrument that asks adolescents to complete tasks. For example, the task of reading a medical leaflet, and then there's there is an objective score that is given to their ability to do so. Now, what the instrument wants to do is to teach transferable skills, skills that can be used in one context, but that can be transferred to other contexts where the reading of a leaflet is again important, and where they can then demonstrate that there has been some improvement in their ability to complete that type of task.
Yeah, thank you. Yeah. So people should check it out and then send these message if additional questions off of the poster. Yeah. And then there's so many subtopics here of, relevance. Julie's concerned, Stacy, about if people are going to be, able to feel comfortable to, disclose. And this is a phenomenon in self-report measures generally. I think that the way that the more elaborate self-report tests are set up in the European, most of the European studies with multiple domains, I think it kind of does normalize in their data for people to disclose. And so, but they're also mostly those data are collected through like survey studies, home survey studies, which is different than like if you're in the doctor's office or something or whatever, some other clinical context, and you get just a single item or a few items. And so like how these things end up getting operationalized can have a big impact on them. So and then
for sure. And to your point, because I think you were kind of doing this in reference to the single item. I mean, I just question how well that single item can really differentiate people. I think I might say I sometimes have a hard time understanding my doctor. So, it's a little bit of that's kind of the whole problem with subjective versus more of test-based tools.
I want to just point out how interesting it is that Inga, you wanted to provide a critique. I think it's an appropriate critique, but you started it off with the word interesting, as if that it was like not a critique. No, it's okay. You're allowed to be critical. It's a horrible question.
It is. Yeah, it's got multiple things in there for sure. Okay. Let me see if there's any others that I've missed here.
You were going to say you've unmuted yourself twice.
Oh, I was just, yeah, it's challenging because then the problem is once again, the data then is the data. You don't know which element they're having trouble with. Is it understanding the provider giving information, which is, or is it that they need help reading? And so it's very difficult. And, regardless of how they answer, you don't know how to interpret the results because they're really asking two things in one. But they're good questions. I just wish they were separated. That's all, into two items. But
Yes, so I think when we phrase questions poorly, then people can also just be confused by the questions. And so there's a whole line of work that can be done about differential item functioning, like how the items themselves function in a biased manner for people who have, say, lower or higher education, and just to interpret and decide how you're going to respond can be messy with some of the way questions are formed. And just as an example, it's extremely common in many surveys and many tools to take some item in the middle and do a reverse coding. It's a very common technique, and usually that's done to say, are the people responding to this survey paying attention? Like an attention thing. But what it does is actually it adds cognitive burden to the experience, and so it basically is just a confusion factor. So I'm not against people paying attention and trying to understand that, but I just don't like it when we end up putting in confusion into the questions and then just basically imbue our tools with bias, basically based on health literacy, basically. Sorry, back to you, Stacey.
Oh, no, that's fine. Well, no, I was going to ask the question about it. I think there was some conversation about folks that were looking at health literacy of Spanish speakers or of individuals who speak a language other than English. And was just going to we've got a couple more minutes left, open up that conversation. If there's any folks that wanted to talk about that, any challenges they have or what they're doing currently, and et cetera.
Yeah, well, I work directly a lot with Spanish-speaking families, and I just see sometimes that the translation, the interpretation, it can be very, very quick or not clear for them, and there's a lot of issues that then when I go and talk to the families and find out that they didn't understand or they understood wrong, and that is right, is how Inga was saying, is it's hard to measure if it's the parents understanding, or if it is the way how the doctor say it, the way how it was interpreted. So it is different factors that at the end is misinformation for parents that can really harm the patient.
Mm-hmm. Yeah, that's a great point. And Janet, I think you had other comments as well. Was there anybody else who?
Yes, hi. As I used to be a medical interpreter as well, my background is in microbiology and public health and health education. But when interpreting for doctors, I understand that the time is limited, the information as well is limited and needs to be just explained fast. And when you call the doctor to, hey, could you explain again, or could you better extend that topic, sometimes they don't have the time, or the patients as well. So it is important that there is more communication among the clinicians, that the output of health information is essential for the outcomes when it comes for better health outcomes in that sense. There are a lot of challenges, and it happens that when Spanish-speaking people, we have people from different countries with different, as well, localism and different terminology, and that also may decrease the information, the knowledge of information as well. So what we do most of the time, we're trying to understand better ahead with the families, to understand more their background. In that way, we understand where they're coming from because not everyone who speaks Spanish, they have limited of technical words. Sometimes there are people that didn't understand English, but they have really a high education background. And so we have to understand which level is the targeted population, and that way what level of education is the targeted population, and that way we know how to then address or give the information that they need in health information. So when we do, for example, presentations, so we try to understand the different number of people, the gender, the age. So in that way, we know exactly how to provide the right information.
It's a great point. Yes, and I'm seeing some comments also about, the coordination between language services, medical interpreters, and clinicians. And yes, for sure, area ripe for research and intervention. Definitely. Okay, well, we have about 5 minutes left, so I'm wondering if there are any burning questions anyone has, or anything that people really want to discuss in our last couple of minutes.
Those who use the screening tool, what is your favorite health literacy screening tool that you guys use?
So I don't do screening, but I will say from a research perspective, I think Michael Pascherella is not going to like this probably, but I tend to use the NVS. I think it usually, it depends on the population, and it depends on a lot of different contexts, but that tends to be the one that I use.
What does NVS stands for?
I'm sorry, the newest vital sign. So it has kind of, it's very numeracy heavy, like it does involve a lot of math skills, but it also has some literacy skills and reading skills in there as well. It's available in English and Spanish. It's relatively quick, depending, it's all relative, I guess. It's certainly not a single item, but there are cons as well, which I'll let Michael talk about.
No, the NVS is has been commonly used. And I've had a long-term active discussion with Barry Weiss about it, with very specific aspects of it. And he's trying to make a specific edit to it. So there might be a new version of the NVS coming out soon. But one of the things that is reasonable to think about for this kind of a question like screening is where do you want to put the bar for how you differentiate? If that someone may have a higher or a lower skill level, and the NVS actually puts the line higher than many other tools. So like NVS is a relatively challenging test if you're in a context where there's a very high rate of low health literacy. So you just have to think of like, what are your goals with these programs, and what are you trying to do? And the NVS is where I used to work, UNG, you were there at BMC. NVS was too hard. And so there was a fair number of people who were a little frustrated because it was a little too hard. It felt testy and it felt hard. So it just depends on where you're working and what kind of scenario you are, how much time you'll have for these things, how are you going to physically be interacting with people. The NVS has an image you have to look at and interpret. If the image is a food label from an ice cream container. It's kind of it has been very useful. It's been very predictive in many projects. So I'm not as denigrating Stacy as you might have thought I was going to be, but I couldn't really use it at BMC. But in my current place, it seems to be working well.
Well, yeah, and I should add, I do mostly work with patients that have QHCs, so I don't think it's maybe that dissimilar from BMC's population, but I also tend to work among younger women and women of reproductive age. So it's a different, that element is different as well when you're talking about, age-related cognitive decline that gets mixed in with health literacy.
Yep.
So. Let's see. So I think we're right at the time. I see a question about funding opportunities. Yes, it'd be great. Someone go out there and demonstrate what we can do with the to help if we screen somebody who has low health literacy. That would be great. To Michael's point, find some evidence base for screening that doesn't currently exist. But that's all. I think we're right at time. So thank you, everyone. I hope folks had opportunity to talk and to connect. And Michael, you had another comment?
Well, just I put the post for the NVS from the tool shed, and if you go to the tool shed, you can see the NVS has been published in, I think, 14 languages or something. It's actually been translated quite a bit. Not all the countries where it was translated, though, did they do the kind of cultural work that needs to be done to make it make sense. But if you're doing it in the US, there's multiple languages available. So thank you for joining this interest group around measurement. There's a ton of issues still to be dealt with in this space. We didn't come anywhere close to finishing with them. So hope that people will have the stamina to continue these topics moving forward. If you find tools that you think should be in the tool shed that we missed, send us a note. You can add tools to the shed. If you have a tool, you can add tools to the shed. We then review and make sure that it's all good, and then we publish it to the shed. In the meantime, hope that you'll come into next room for the next session for HARC. Thank you, Stacy, for coordinating this session, and join us in one of the session in one of the two links for the next part of this conference.
Great. Thanks, y'all. Bye.